And I am a very happy employee of Aspirus Riverview, and we bring to you tonight Agony of Defeat with Dr. James Torhorst, who, trust me ladies, this is a presentation. If you have a membership card in your packet, that means you haven't signed up as to be an aspiring woman. And who doesn't want to be an aspiring woman, I'm thinking? But the benefits of being an aspiring woman is you will get periodic newsletters that just come to your email with healthy tips. You will get a pre-invitation, so to speak, to our presentations. It doesn't cost anything. We have a website that has recipes on it and that kind of thing, so it's fun. So we will have a presentation, our presentation tonight. We will have questions and answers. We will have door prizes, of course, and then as you leave, we will have an Aspirus Aspiring Women gift. And I will tell you that Dr. Torhorst is just great about staying around afterwards and asking you and talking to you about your specific questions. We also have the opportunity for you to sign a card that's out on the table, and you can make an appointment with him if you want to. We'll call you and get you in at a convenient time. So, without further ado, I'd like to talk to you a little bit about shoes, because I personally love shoes. I don't know about you, but I love them. And so I looked up whether there was a science behind that. Why do women love shoes? Because most of us do. And here's what I found out. Long before spiked heels became objects of desire, women have been shoe crazy. But recently, we got proof of this because during the recession, all sales plummeted with the exception of shoes. In fact, the sale of shoes went up. For me, buying a pair of shoes has always been a near supernatural feeling. Like instantly updating an outfit from last year or just making myself feel attractive. But that doesn't fully explain how footwear is beating the odds. Trust science to have the answer. It turns out we have been wired for shoe lust even when the going gets tough. First of all, apparently there is some serious mind boosting going on when you try on any kind of apparel. I can believe that. The neurotransmitter dopamine, we've all heard about dopamine that we get when we exercise. Well, apparently dopamine is also released and provides a feeling similar to getting high when you try on clothing. This is according to Morton, who is the author of Biology, The Truth and Lies About Why We Buy. Oh, people are chattering back there. They all get it. Everybody gets it. The dopamine actually increases until you pay for the item. Not a surprise. Usually the high then flatlines and the guilt starts creeping in, except when you are buying shoes. Somehow they figure that shoppers rationalize shoes as a practical buy, something they can wear multiple times a week, so they hold on to that pleasurable feeling longer. But it's not just dopamine at work. Shoes' mood-altering traits also come from another brain reaction. Buying new footwear stimulates an area of the brain's prefrontal cortex termed the collecting spot. Shoes are a collector's item, whether women realize that they are or not. All of those wonderful feelings are intensified when you choose high heel shoes. But again, it's biology, not Jimmy Choo at work. Like most animals, we're wired to associate height with power. High heels can literally raise your status because you're taller when you wear them. So I should really wear really tall heels. I'm afraid I'll fall over. That's the problem. But here's the most interesting part. It's called sexual healing. Get it? Play on words, healing. Got it? So there's more to to it than just how great you look in your shoes. According to Daniel M. Amen, MD, author of The Brain in Love, our minds are structured in a way that may associate feet with sex. The area of the brain that is connected with sex is right next to the area that deals with the feet. Who knew this? These regions share neural crosstalk, which may be why we find shoes somewhat erotic. And we thought it was just our lust for beautiful shoes. And on a final note, one day my wonderful husband, Pete, dared to count the number of shoes I have. Really, what was he thinking? No, he had no idea I had that many pairs. And he said to me, if you can believe this, he said, "How many pairs of black shoes do you need?" And I said, "One more than is currently in my closet." And then he said to me, "Buy anything you want, but do not come home with another shoe box." And I don't. I leave the box at the store. Now I would love to introduce you to Dr. James D. Torhorst, better known as JD. He received his Doctor of Podiatric Medicine, at Des Moines University, and did his residency at Jewish Hospital in Louisville, Kentucky. Dr. Torhorst is board certified in podiatric medicine. He is a fellow of the American College of Foot and Ankle Surgeons, and he is also a fellow of the American College of Foot and Ankle Orthopedics and Medicine, which is a national organization of highly educated and trained podiatric physicians. Dr. Torhorst is the only doctor I know who gives his cell phone number to his patients. Never seen that before. He puts more hours in a day than seems humanly possible for all of his patients. He has fixed foot and ankle issues that his patients suffered with for years. He is also a great presenter, which you will find out tonight, and I know you will enjoy his presentation. More importantly, Dr. Torhorst has a lovely family. His wife, Carrie, and his mother and mother-in-law have joined us tonight. Together, he and Carrie have 2 beautiful daughters and a son. And when he is not working, which is much of the time, Dr. Torhorst enjoys spending time with his family. So without further ado, let me introduce Dr. Torhorst and his fine-looking shoes.
Thank you, Nan. Nan has the cutest shoes in the hospital, and she always has. I noticed it the first day. And she purposely didn't wear heels tonight, so I wouldn't give her a hard time. She had a pair of stilettos on you wouldn't believe when we gave this lecture down in Rapids. They were cute. All right, well, we're going to go through things. Can everybody hear me all right? Okay, and I can walk around a little bit. So thank you to my mother, and thank you to my mother-in-law and my wife for being here. And my mother-in-law stained our deck today. Thank you, Mary. It was awesome. I can fix ankles, but I am no good at that stuff. So we're going to kind of roll through some common problems people have with their feet, and we'll go through some questions that you have, and feel free to jump in and blurt things out anytime. I see some of my patients here, you know that's kind of how I am. Just go ahead and talk. I'll probably be talking, just interrupt me. So Nan talked a little bit about some of the things that I do. We're gonna, is it the bottom button, Nano? Got it, okay. So this is me, and I think that the slides are the same as the ones I have, so I don't have to sneak over. Basically, Nan took you through board certification. Board certification is important when you're picking a surgeon. I think it's a wonderful thing to have a surgeon who's board certified. I do a little bit of consulting work for some of the companies in my industry, help design some of the screws and plates that we use in the operating room, have designed some of the things that are in some of the patients I see here today. So the lecture will begin talking about, there we go. So we've all been there. Feet hurting from the wrong types of shoes, improper fit, constantly wearing heels, being active. The those types of things are all things that I encourage. I trained at the University of Louisville, worked on a lot of athletes, worked on a lot of people who were very active, and I carry that over into my practice. Anybody can make you feel better by saying go sit in the bed all day and don't do anything. The trick is trying to get you up and get you active and keep you going. I think in today's society that's really important. It's so easy to sit in front of the computer or to use your feet as a reason not to do things. If we can keep you up and keep you going, that's always my goal. Some of the problems that we're going to talk about are bunions, hammer toes, heel spurs, plantar fasciitis, ankle instability. Those are some pretty common things, kind of the big five in my practice. I'm just going to sneak over here. All right, so yeah, flat feet are a good one too, but you can't say flat feet anymore. You got to say pes plano valgus or the federal government won't cover your insurance claim. So, as we look at some of these slides, the first slide is bunions, and lots of people have bunions, and lots of people have misconceptions about bunions and what causes bunions. And what I always tell people is don't beat yourself up. It's not because you wore too small shoes or anything when you were a kid. The way I describe it best is tribes in Africa who've never worn shoes a day in their life have bunions, and so it's really a biomechanical problem. And it's a biomechanical fix. It's a very difficult surgery to perform, so we try to stay out of surgery if we can. Appropriate shoe gear, applying pads to the affected areas, medications, anti-inflammatories, those are all great things. Bunions are a real problem. Lots of people have them and they're progressive, and so it's really good to get in and see a foot and ankle specialist who knows when your bunion needs to be fixed. Some people won't progress, and if you get orthotics or you control your biomechanical deformities, you're able to control your bunion. If you don't, sometimes that bunion can get so bad that it affects your second toe, your second MTPJ, and those are problems that usually bring people into my office for pain, and that's when we're in trouble. So if you can get there before that, you can usually avoid it. Hammer toe deformity. Some people think about their grandmother's hammer toes. Hammer toes come in all shapes and forms. There's claw toes, hammer toes. Again, it's a biomechanical deformity due to instability. You can treat it surgically, and you can treat it with wearing shoes that kind of offload that area, wider toe box. The European style shoes are really becoming back in favor again and becoming more fashionable. Not for Nan, but for a lot of people. So the wider toe box and trying to avoid rubbing is fine. If the hammer toe is progressing and dislocating at the metatarsal phalangeal joint, we have a bigger problem that we have to address, and so we try to pay attention to that. Again, it's something that I really recommend you get in and see a foot and ankle surgeon about, because you can usually avoid surgery if you get there early enough. Etiologies of hammer toes, this is some pretty boring stuff. This is like, flexor stabilization, flexor substitution, extensor substitution. When I trained down in Kentucky at the university, horses made sense to people, so I always talked about the reins of a horse, and all the tendons in your foot are like the reins of a horse, and as soon as you get some instability and one gains a mechanical advantage over another, you can have lots of problems with your feet, and we can usually control that with shoe gear or structural orthotics. And so we'll just kind of keep rolling here. Heel spurs and plantar fasciitis, the most common thing I see in my practice. Lots of people have plantar fasciitis. I've had it. I developed it in residency standing all the time, and as soon as I don't do my stretches for about a week, if we go to Florida or do something with the kids, it comes back. And so something we can definitely treat in the office. We do a lot of injections for this. Icing, stretching, anti-inflammatories. Surgery is very rare and relatively unsuccessful compared to other surgeries, and so we try to avoid it when we can. Again, getting in early is a good thing. So that'd be non-steroidal anti-inflammatory, so ibuprofen and those types of things. I'm gonna just take my jacket off, it's kind of hot up here. Yeah, easy, ladies. And I'm sorry about the horizontal stripes. I meant to go vertical, but I wanted to wear pink today. So here's the surgery, and so I do a lot of arthroscopy and have kind of developed a niche, and this is going off on a tangent, but medicine has changed a lot recently, and I think for the better and for the worse. It's hard to find a doctor who knows you like your old family doctor used to, so there's more specialization. The nice thing about specialization is you got guys like me who do a couple things really, really well, and we are constantly developing things in our area. So if you can get to the right person, We do a lot of things through a scope. So we used to make a big incision on the bottom of the foot. People couldn't walk for 3 months. Now I go in with a scope and you walk right out the door. This is your plantar fascia. These pictures don't translate very well. This is the blunt probe that I use to go across the side of your foot to find the plantar fascia on the bottom of your foot. And then I take a little triangular blade, and that white part up on top is the fascia, and as I cut through it, that's a better picture, you can see the blade hitting the... We basically pre-measure it. I used some x-rays from before, and we figure out where the medial 1/3 of the plantar fascia is, and we transect it, and you can see it opening up, and you can kind of feel the foot give, which biomechanically changes everything and usually alleviates the patient's pain. Morton's Neuroma. It feels like you're walking on a marble. My patients a lot of times say it feels like you're walking on a balled up sock. Oh, hey, Jody. So there's Jody and Jody. Jody Dombeck is my original MA, so hello, thanks for coming. She left me, moved up Stevens Point, that's all right. So Morton's Neuroma is something that'll catch a lot of people, and it's something you can treat, again, with orthotics, or you can treat with an injection very successfully. Again, something we want to get in early to see, and this is one of those things where shoes can affect you. Tight shoes, squeezing shoes, shoes that kind of pinch your toes together. The metatarsal heads can become squeezed, the nerve inflames, and that central nerve, is there a pointer on this? No, probably not. That central nerve that you see becomes bulbous, and then sometimes we even have to cut it out, but that's, again, pretty rare. Fungal nails. So I had a couple ladies ask me about this while we were eating, which is always nice. It's not as bad as it. My father was an OBGYN, and now that Nan had that part of her topic, I guess that's not such a stress that I'm a foot guy. But those conversations at the dinner table were sometimes even worse. But yeah, the fungal nails are a real problem, and lots of people have them. And trying to beat yourself up over where did I get them? Did I get them from a hotel? Did I get them from the pool? Is it Leah's fault? No, it's not. It's everywhere. I think of it like the cold virus. And so the fungus will get in your nails, and it's hard to get out. It's good to come in and see a person who deals with this stuff all the time. So fungal toenails sometimes need to be removed, partially or totally. Hi, ladies. And so if you're having trouble with your nails, there's topical antifungals, there's oral antifungals that can be hard on your liver. There's new ones that you're seeing on TV now, like Julia and all these other things. They can be very expensive, they may not be covered by your insurance company. Go in, talk to somebody who knows about these things and deals with them all the time. Foot malalignment. Everything we talked about today is due to foot malalignment. Even your fungal toenails are usually caused by your foot not being aligned quite right, a hammer toe deformity, a bunion deformity, and then you end up with fungal toenails because they're ramming in the end of your shoe. This is more talking about metatarsalgia. The metatarsal bones, long bones of your foot. This is a very common problem, and this is the thing that brings people in when their bunion deformities go unchecked. This is a surgery a couple surgeries I did, in fact. Yeah, this picture may look very familiar to somebody in this room. Sometimes you're doing a bunion surgery and the second metatarsal head has actually already been destroyed. And so if you can see, the cartilage on that second metatarsal is worn right off. If you let things go too long, you get what I call unfixable or very difficult to treat. A replacement joint on the second metatarsal phalangeal joint is a very difficult thing to live with. And so you want to get in and get these things taken care of before you're at that level. Yeah, arrange for a consult. These are some of Nan's pictures. Those are, it's amazing what you see. And, high heels like that, that's something that you always worry about people's ankles, but also that forefoot, you can really have some problems, neuromas. All these things we talked about can be not necessarily caused by, but certainly exacerbated by your shoe gear, and therefore relieved by proper shoe gear. Nan's story about buying shoes was pretty good. My mother, who's here today, I can still remember being a child, and my father saying, JD, you don't ever want to be the guy who answers the phone and the department store called because they had your mother's shoe size in. So, my mom always had a size 5, so yeah. But yeah, buying shoes is fun, and shoes are changing, and I think the European style shoes, especially sandals, are really coming around where you can wear flip-flop sandals that support your arch the way they're supposed to. So don't be stressed out. You know, I really think it's important to, you know, educate yourself. The internet is a wonderful thing and a terrible thing all rolled into one. I encourage all my patients to go read, educate yourself, come in with as much knowledge as you can, and then I'll decide for what I think is right and what I think is wrong. When you're having foot problems, it's important that you see somebody who deals with foot and ankle problems all the time. I think sometimes it's one of those things that, oh, it's just your foot, oh, it's just a bunion. They can really lead to big problems, and so one thing that I really stress in my practice is try to get your friends and family in before they have a big problem. We're going to talk a little bit about ankle anatomy and some of the things that we do at the hospital. Does anybody have any quick questions about some of that foot stuff? Okay. Yeah. Everybody's coming in, yeah, okay, well, that's all right.
Talk about high arches.
High arches, cavo-varus foot type. So if you have a high arch or a cavo-varus foot type, you lend yourself to metatarsalgia, hammer-toe deformity. That would be flexor stabilization. Your tendons being malaligned through your midfoot, and so the high arch needs to be supported. And what you want to think of is bring your ground up to your foot. So wearing shoes that have a high supported medial arch, maybe wearing shoes with a metatarsal pad, maybe getting inserts that make all of your shoes appropriate shoes. Those are the things that you want to think about when you have a high arch foot. Depending upon your age, women's feet, sometimes during pregnancy when their body's sending messages to have their ligaments widen, that doesn't just go where it needs to go, it goes to your feet too, and that's when people with high arches can end up with fallen arches, and then that's when you get plantar fasciitis and those problems. So a cavo-varus foot type or a high arch foot, do you have a specific question about that? Okay, yeah, I think orthotics are a wonderful thing. Orthotics have changed a lot. You know, when I went into podiatry over 10 years ago, you could still kind of have your own shop and do your own thing. Most of us are now employed by hospitals. Yes, Stephanie?
So for somebody that's not going to stop wearing heels or stop wearing flip-flops.
Right, which I would never tell someone not to.
Then was 4 inches the max in the heel? What would you recommend?
Another moment in my life with really cute shoes here. I don't really, this is one thing I always say to people when they're talking about shoes. You are not a size 8, and there are no rules. And so the most important thing is try the shoe on. You might be a 10 in one brand and a 6 in another. Make sure they fit. Walk around in them. Don't be shy to take them back. You know, in this community we do a lot of online shopping. Learn how to go to the UPS store in the whatever place behind our house and send it back. Make sure your shoes are right for you. I don't have a height restriction.
But does right just mean comfortable? Or?
Right means, and this is where I really do believe, somebody like me who understands the biomechanics of your particular foot type. So, you know, looking at your foot, you know, you can, if you get x-rays, you can see things like a cavus foot, a high arch foot type. Certain types of shoes are going to be more effective for you. Sometimes high heels are the right thing. Sometimes an elevated heel is a good thing for your foot type. You know, 4-inch heels, I don't know. That's all right. I know you got to wear them, but you know that might be a little high. But I'm certainly not going to tell you not to wear them. I think what you need to do is you need to find out what kind of foot type you have, what are the appropriate shoes for you, and try to find somebody who understands it. There's also shoe stores who employ podorthists who sometimes know some of the things. They tend to treat everybody for plantar fasciitis. That may not be you. So I would say go see a podiatrist or a foot and ankle surgeon and talk to them. Yes, Liz.
I'm kind of giving you a layup here.
A layup. I'll take it.
So, my husband says, so you should only wear flats.
Right.
You
No,
know, that's what
right.
the philosophy is.
Exactly. No, and I don't believe that is true. I think that you should, again, it goes right into what I just said. I think you should wear shoes that are appropriate for your foot type. Your particular problem may be something that you benefit from a little bit of a heel, from a medial arch support, from different types of sandals, and to be honest with you, flats are probably not the best shoes to wear. particularly if you have a cavo varus foot type with a collapsing medial arch, if you have plantar fasciitis, if you have some of these biomechanical deformities that need a medial arch support, bringing the ground up to your foot is not done in a pair of flats.
So we can tell our husbands that heels are good.
You can tell your husbands that heels are good. And don't bring the box home, I've learned that too. Yes, ma'am?
Are there specific consequences to squeezing your feet into shoes that are too short for you, when your toe is right up?
Too short, and I'll tell you, this is the biggest thing that I see in my practice, honestly, and this goes to fungal nails and to neuromas and to all those other things. People come in the wrong size shoes a lot. First of all, your feet change over time, okay? So you might not be a size 8, you might be a size 6, but for years you thought you were a size 8, or vice versa. Usually it's the other way. Usually I've always been a 7. I'm not going to get these 9s, and you know, I know a tall blonde woman who does this all the time. I know her really well. She is not going to wear an 11, but sometimes you are an 11, even if you're normally a 9. Short shoes are trouble, and they're trouble. That is one thing that can cause a foot problem. You don't have room when you walk and you push through it. And it is what we were talking about with the orthotics. People used to have orthotics that the podiatrists all made their own orthotics, and you could tweak them, and no one really does that. Well, not no one, but very few people do that anymore. You know, they send them off, which is good and bad. The company I use is out of Seattle, Washington. They're very, very good. You know, Jody basically got that all started for us, and we send it off to them. They send them back. We take a little foam mold of your foot, which has been proven over and over again to be better than casting. The foam mold allows them to make the orthotic. Then they give us 6 months to change them any way we want to, which is really nice. So, you know, go somewhere where your orthotics can be altered.
Not covered by Medicare.
Correct.
$88 these days?
Yeah, I don't know what ours were. Jody, ours were somewhere between 4 and 6. Do you even remember? How much the orthotics cost?
Anywhere between the 400 and 600.
Yeah, it kind of depended, and I know the other girl in our town, they're 900, and I've got friends who sell them for 1,000. So insurance companies are covering less and less, and it's hard. And we've tried to make modalities. We sell some little $40 over-the-counter ones, and then we try to alter them the best we can. And you want to make sure you want them and you need them before you get them too. So that's another reason why, you know, without mentioning names, I mean, going and stepping on a machine or going to a company where maybe they don't really know your foot type and your x-rays and what's going on with you, and they have a limited knowledge of biomechanics and particularly surgical biomechanics, might not be the best thing. You might want to see somebody who can x-ray you, assess you, and then get you the right orthotics, because $488 is great if you need them. If they're no good, it's a real bite.
When you do yours, do you pour the mold?
You step into a foam box, so it's a box filled with foam, which they've proven over and over again now that it's more. What happened with the casting is when you remove the cast, the plaster cast would deform a bit as it came off your foot. The foam does not. So we take a foam impression, we mail it to Washington, and they mail it back.
Mine work fine. I've had them for 5 years.
Yeah, and they should last forever.
Oh, really?
Yep, and you can do it every which way, but that's how we do it. Absolutely. I'm not saying there's anything wrong with it. I'm just saying that science has proven now that these foam boxes are really working pretty well.
Maybe they don't, where I went, maybe Larry doesn't do it anymore.
And they may not. You know, the reason I wanted to go into this, to have my own business and do all those things, that it's kind of becoming a thing of the past, which again, with the evolution of medicine, there's good and there's bad. And so you got to kind of look at it both ways. One of the things that's been lost is the true art of making orthotics well. Yeah, I would agree with that. So now there's companies doing it for us, so I can do arthroscopic ankle surgery. Yeah. So that it's, if you can find a place and you find somebody who's good, stick with them, and your orthotics should last forever. That's the other nice thing is your custom orthotics, like this lady's saying, that instead of buying something for $50 every year, you buy them once for $500, they last forever.
Yeah, I've been told 3 to 5 years, and they're the $500 because you're always changing.
I'm not sure where you're getting them, but I know in our practice, our $500-ish ones, I've been out long enough to see that they just don't really break down. And there's a guy in town who made them similar to the way we make them, and I see patients who had them for 30 years. Now your foot type can change, but they shouldn't break, depending upon what they're made out of, they shouldn't break down. It's hard, and this is one of the things that's changed a lot is my company can make a dress shoe orthotic or a bulky orthotic, so like for your running shoe, but you can also have one for your work shoe. Not quite as effective sometimes, depending upon your foot type, depending upon what we're trying to accomplish. So it's a real fine line, and it's almost impossible to go through it all today, but it's quite a science, yeah. But there's lots of orthotics you can get for different types of shoes, and there's now lots of sandals you can buy that have kind of that arch built into them.
Do you buy the over-the-counter orthotics, like the super speed or whatever? How long do those last?
On a fat guy like me, they last about 4 months. On a little person like you, they could last up to a year. Depending upon if you're running or if you're waiting tables or cutting hair versus sitting behind a desk, it makes a big difference. Yes, ma'am.
So I have a pair of orthotics from pretty many years ago,
Mm-hmm.
and then I buy sandals with, orthotic. Isn't that kind of like, is that good or bad? Because this isn't like the same as my.
Correct. With your cable varus foot type, you're going to want as much arch support as you can get. So if you're going to wear sandals and you can't wear your orthotics, you want to do just what you did, which is buy sandals with medial arch support in it.
Right, okay, so that it's okay that even though it's.
It's
not-
okay. It's not a perfect world.
Not the same as my.
What would be the best for you? Wearing your custom orthotics and a pair of clunky tennis shoes every day for the rest of your life. Is that realistic? Probably not.
Right, so it's not necessarily like, that's what I do.
I don't think so, and I don't look at it as that. I look at it as you're doing the best you can do and living in the real world.
And so you buy a sandal with a bed that can be removed, like an AOS, and put your orthotic?
You can do that, or you can buy the sandals that are kind of built up already and they don't remove. Nails are a wonderful brand. There's more and more of them coming out all the time.
So wear them without your orthotic?
You can, sure.
Nice if they didn't make them the right way.
There's, I just went and checked them out. If you go to even Madison, but if you go to Chicago and we were down on Michigan Avenue, I mean, it's amazing what's out there now. There really is nice stuff, and what you do is you find a kind that works for you, and then you buy them online or buy them.
Can you name a few of the brands?
Anything of the European, so Merrill, Birkenstock is now coming back around and having a bunch of cute shoes, and so that's always a good one. Yep, Danskos are what I wear in surgery, and they're white. I won't take it personally that you don't like the white shoes. They make me taller, that's why I like them. Yep, they're very good. Bionic is interesting. Bionic has come out with these new shoes. They're really, really good. It's a very specific foot type usually. So if it's plantar fasciitis and medial arch support that you need, they're usually fantastic. If it's not, they may be, if you have metatarsalgia or hammer toes or forefoot pain, and you overload your forefoot with a heel lift and a medial arch support, you can cause damage. So it's hard. You got to kind of understand what you're going for, and then something, if it doesn't work, send it back. You'll know when you put it on. Walk around in it for a day, you'll know.
Who's the best to fit you for that kind of stuff? Because I
Me.
had a chiropractor
Yeah.
that did my foot years ago. So are
Yeah.
you qualified to do that?
Absolutely, and some of those guys are fantastic. Their orthotics usually tend to be, they're structural and functional orthotics. In other words, there's orthotics that try to kind of just mold around your foot. Then there's orthotics that are trying to do something like push up your medial arch, keep you from having posterior tibial tendon dysfunction in a flat foot. Most of the, at least in my area, which is through here, most of the chiropractic care that I've seen, those orthotics are very, very good for kind of padding and getting things done on a structural way. I would say, I tell my patients all the time to try them through their chiropractor's office, and I've been very impressed with what I've seen. It just really, really depends on what you're doing. Most chiropractors aren't going to take weight-bearing x-rays of your feet and have a knowledge surgically and biomechanically to address you that way. They're going to know your leg length discrepancies. They're very good at that. They're going to know sciatica and hip pain. They're going to get you even, and they're going to say that's good, which may be what you need. But if you need more than that, then you may be left wanting, yeah.
When you talk about biomechanics, are you talking about analysis of the walk?
Right. In biomechanical deformities, like the things we talked about, bunions, hammer toes, metatarsalgia, neuromas, things where the bones aren't quite perfect anymore or never were. And that can be caused by a number of different things. And then it can be treated a number of different ways. You know, with surgery being the end route, I always think being a good surgeon makes me a better conservative physician because I understand what I'm trying to avoid.
When is a good time to evaluate children so they don't have these problems?
Children's feet are great to see when they're little, in the sense that you want them up, you want them walking, you're not going to do much, and there's curly toes, there's pediatric flat foot, there's high arch feet in children, there's vertical talus, there's coalitions, there's a million different things that can cause problems with children's feet. If your children are complaining of going to the mall or walking or gym class, you go take them in. Usually, you know, when parents bring me a kid who's 2 and they're just walking, there's not a whole lot I usually do for them because we want to kind of let the foot develop a little bit. Anywhere between age 4 and 6 is a great time to assess things like coalitions and problems that may respond well to orthotics or splinting or casting in children. Now, a club foot is treated at birth, but you know, the things I think you're talking about, if you can get an orthotic in that child's foot, you can help them, you know, prevent them from having a terrible flat foot. Or maybe they need a surgery, maybe they need a calcaneal osteotomy. I do an arthroeresis. I put a little tiny peg in these little kids' feet so that they can't grow flat. They have to grow correctly. It's a 2-minute surgery that is really, really helpful, but you got to know what you're doing and you have to have been trained in that. So at the University of Louisville, I did pediatric orthopedics for 5 months out of my 3 years, and so if you've got somebody who's got that kind of training and understanding, it's a good thing to take a kid in and have them take a look at it. Yes?
What are the best shoes to wear if you have flat feet?
Again, it depends on if your flat foot is rigid or if your flat foot has a reproducible medial arch, which is tough. There's a thing called a Hoopshire maneuver where I put you on the floor and I pick your toe up, and if your arch goes whoop, then you would do great with something that has a medial arch support. If you have a rigid flat foot deformity, then we're talking about an orthotic that may be trying to position itself around your flat foot that is now a bony impingement, or perhaps a posterior tibial tendon dysfunction or failure. Can you go up on your toes? Can you do it on one foot?
I don't have any problems, but
If you can do all those things and you develop flat feet over time, not you were born with them, probably a medial arch, oh, you were born with them? I always tell patients like you, come in, let me see you, let me get an x-ray. I mean, you could have a little coalition, you could have something that we can actually make it worse by trying to push on your medial arch. So you want to have your posterior tibial tendon assessed, and you want to make sure you're doing the right things before you go trying to change it with a shoe.
We're wondering what coalition is.
Coalition is when your bones don't grow apart the way they're supposed to. So, a calcaneal-navicular coalition would be your heel bone connected to a little bone that lives up on top of your foot. That's a very common one. 48% of coalitions in foot and ankle are of that type. Kids will have a flat foot or pes planus. They'll complain of pain. They'll have equinus or tightness in their posterior muscle group. And it's a diagnosis made with an MRI or a CT eventually, but if you have a clinical suspicion, you pick up on it. Lots of people don't get diagnosed, and then they end up with a really bad ankle fracture or lateral ankle instability, which is something I see a lot of, which we're going to talk about here in a minute. So it's like your bones have a bridge. Sometimes it's cartilaginous, sometimes it's bony. Usually it's cartilaginous, so it's hard to see. They'll miss it on an x-ray. You got to get an MRI or a CT with contrast to really pick it up. And again, it's one of those things that you want to look into your doctors. You want, in today's world, take the good with the bad. The good is there's guys out there like me who spent 3 years and did 3,000 surgeries on foot and ankle, kids, adults. I mean, if it's wrong with your foot, I can probably figure it out. Because some of those things are really hard, and feet are confusing, and you know, a specialist can be a great thing in a situation like that. Let's talk about ankles quick. These are more boring little doctor slides here, but we'll just kind of show you the anatomy of the ankle joint, sprains and ruptures. What happens is a lot of people sprain their ankles, and sometimes that's a predisposition because of your foot type. Cable-varus foot type people are very prone to ankle inversion injuries.
Does that mean pronation, or what are you saying?
Well, pronation is flat, supination is cavus. So pronation is a flat foot. A cable-varus foot type would be supination. Think of a cup of soup. So, no, the other way. So a cable-varus foot type is more often the people who are rolling their ankles repeatedly and getting recurrent ankle sprains and then ankle instability. This is presentation when the patients come in, and these are the things that we pick up on. You're getting lots of ankle sprains, your recurrent ankle sprains, you have that chronic swelling, kind of that anterior lateral swollen ankle. You feel unstable. A lot of times they talk about it. I feel when I walk on uneven ground, I feel like I'm going to roll my ankle. These are some pictures of what's called talar tilt, the anterior drawer. You come and see a guy like me, I pull your ankle. If it separates in like a suction cup, you're probably one of mine. Conservative treatment, we always try this first, because if you have been just recurrently rolling your ankle and we can keep it still for 6-8 weeks and allow the ligaments and everything to heal, that can be the best. Rehabilitation, physical therapy, I'm a huge believer in all of it. Long-term bracing, you know, when I moved to this community, central Wisconsin, there wasn't anybody doing these things, and I'm one of 4 guys in the state who do them through a scope. There were people who were in braces for 10 years when I came here who said, oh, I didn't know I could fix that. It's okay to be in a brace for 10 years if that's what you want and you want to avoid surgery, but if you can have a 19-minute surgery and not wear a brace again, I always think that that's something, at least an option you should talk about. Yeah, these are all. So, you know, it's confusing, and it's a lot of information, and it seems overwhelming sometimes, and again, this takes me right back to what I always say, which is there are people out there who specialize just in this problem. I mean, come and see one of us. If you're rolling your ankle, if you're feeling unstable, if you have something wrong with your feet, come and see a foot or ankle person and let them take a look at you and see what they think. And if the office visit is, hey, you know what, you're fine, great, then you know. So arthroscopy is something that I'm very passionate about. I do a lot of ankle scopes. It's a skill that is rare. I knew I wanted to do it when I was in residency, so at the University of Louisville it was great because there were guys who did it. I used to have to drive 2 hours to go see this guy. I don't even remember what the name of that town was. It was Eastern Kentucky. It was scary. But he was a great surgeon. He did a lot of arthroscopy. People came from a long way away to have him do it. The benefits of arthroscopy, this was a nurse who worked in the hospital who, for 5 years before I came, walked around with pain. She didn't know what had happened. And so we went in, scoped her ankle, and she had a big hole in her talus. And so when you've got bone-on-bone pain, it doesn't always get seen on an MRI, doesn't always get seen on a plain film. So an arthroscopy, which is 2 little incisions and about a 10-minute surgery, can sometimes go in and fix something like this. And you know, she's one of my favorite people to see at the hospital because she's always out walking now. I did this one last week. It's just the biggest piece of bone I've ever seen in an ankle. Jody, I thought about you. I remember when I brought that one upstairs. This guy's ankle was, so this guy walked around with this for years. It's a loose body, we call it. And you can see my instrument in the back. I actually had to go in and cut it. My instrument couldn't grab it. I cut it in half, and I still had to make his portal incision bigger to get it out. But these are the kinds of things. This guy had multiple x-rays. He'd seen multiple physicians, and everybody said, you're fine. He had about 6 of them in his ankle, and it was impressive. What you see through a scope is really cool. You know, you can go in, you could have an MRI, you could have a CT, you can do all these testings. It's amazing, MRIs, CTs, it's all great. Science is awesome. The technology in today's medicine is so amazing. It's so much more amazing today than it was 10 years ago when I was in residency. It's awesome. But a scope and going in and looking at something and being able to fix it is really very powerful. And I can't tell you how many MRIs I've seen that are read as normal, and the patient you just start to hear these people, there's something wrong. So we go and scope the ankle and we find something. This is just my technique. This is the arthrobostrum, which is something I lecture on and I teach a little bit. The instruments, it's amazing the stuff that they have. These biocomposite anchors. Basically, we screw them in, they become bone in 6 months, and then you've got your sutures just left holding the ligament back in place. So we go in, we debride the ankle with a shaver blade. 3.5 millimeters, it looks huge here, but that's all the bigger that is. And we use a 2.7 30-degree beveled arthroscope so we can see without doing a lot of damage to the ankle joint itself. Put you in a little distractor, clean everything up, and then we've placed the anchors in the fibula, and then the sutures are going to be passed down through the ligament, all arthroscopically and under the skin. We used to make a big incision. Almost everything from this blue strap all the way up to what you could see was a big incision, and people were 3 months not walking, and lots of wound complications, lots of problems. This is what an ankle looks like when I go into it a lot of times. You can't see a thing. It's a whiteout. That's all synovitis and scar bands and tissue that shouldn't be there. So we clean that up so we can see. So there's a shaver blade doing some work for me. This is what it looks like afterwards. So, you know, we start with this, we clean everything up, and we get to here. There was a lot of research about 20 years ago on knee arthroscopy. Knee scopes were shown to do a lot of good for people just if you went in and cleaned them up. Their knee pain was very often better. I'm finding the same thing with ankles. It's just kind of a new science. This is a grasper that we go in and we bite away soft tissue and take away loose bodies and things like you saw. This is a co-ablator, which I don't use anymore. This is electrofrequency. You can actually burn the tissue away. I just don't need to use it anymore. I got good enough that I don't need to. There's nothing wrong with it, but you can have some cartilage damage with that heat, so I've kind of stayed away from those. This is me drilling the holes in the fibula. You can see the exposed bone that we've cleaned off, and this is all through a little tiny ½ centimeter incision. This is me passing the sutures. You can see the 2 anchors have been thrown. Then I come down through the ligament, through the extensor retinaculum, all the ligaments that are torn on your ankle that are making you loose. We gather them up, and we pull them tight right down to these 2 holes. This is where your ligament used to live, on your distal fibula. This is kind of a good picture of the bone. This guy hit a deer on his bike. Jody knows who this guy is. He's a character. But yeah, he was a terrible ankle. And then we pass him through the skin, we make an incision, and one of the things that was hard for me to always understand with this is there's nerves under there, so how do we know we're not going to hit the nerves? I had to go and the first probably 50 of these I opened them afterwards to make sure I wasn't entrapping the nerve, because I'm just kind of a nervous guy like that. I'm a detail guy. You know, we've had good luck, and most of the literature that's out there, most people are not hitting the intermediate dorsocutaneous nerve, which lives in this area, but that's always a concern. So if you make your incision the long way, what I've learned is you course along the nerve, and then you can stay below it. Even if you don't see it, you still don't catch it. Here's the big seller. Post-op. Post-op is amazing. Used to be 3 months. You were in a cast doing nothing. I now get some of my patients up at 2 weeks and walk them. I had a little 19-year-old girl. We did her other side. Cute little hygienist, and she, I couldn't say no to her. So she was like, I want to do this, that. So we got her up, got her walking at 2 weeks. She's done great. We did her other side. We did 2 weeks again. She did great. A lot of guys are doing 2 weeks. My friend over in Green Bay who does these is doing them in 2 weeks. It's really been, the recovery's amazing. Back to sports at 3 months. I'll tell you what, I'm a little more conservative than that. It depends on your sport. Track, sure, you can run straight. I'm good with that. Basketball, tennis, we may want to wait a little bit, or we may supplement with a brace going forward. My observations were basically what I've already talked to you about. It's just, it's such an amazing procedure. I love doing it, and my patients are so happy. This is my favorite case to do. And it's a cool thing because it's, here we are in central Wisconsin where this isn't Mayo, this isn't, whatever. And the Riverview Hospital has been fantastic, and now Aspira's taking over Riverview. They've encouraged those of us who know what we're doing to keep doing these cutting edge things, and it's just been awesome. And I do less and less traveling and teaching because I'm working all the time now, but it's really been a cool thing, and there is good healthcare in this area, and I do think one of my passions is trying to stop this outflow from Stevens Point down to Madison or Milwaukee. I know the guys down there who are doing these things. I think you're in better hands here. So, talk to your family care doctors, do some research, go online. There's great healthcare right here in the community. Riverview is just right down the road. It's not that far. I know everybody thinks it's so far away, but consider keeping your healthcare local if you can. Here's 1 week post-op. These people used to be just swollen and miserable with this big incision and all this pain, and most of my patients come back in about a week and they look fantastic. This is just a summary. I've been barking at you about it already. And there's my crew. So that's something I'm passionate about. The Riverview and Aspira's Riverview has now been fantastic. They let us do all kinds of things. We're flying in a fresh frozen tailless from Florida for a case I'm doing on Friday where I'm cutting half of a lady's ankle joint out. What's that? Is that a fish? That's a tilapia. Yeah. No, and so it's great. I mean, we're doing all kinds of really cool things here, and we're going to replace this lady's ankle with a graft from Florida. Medicine has changed so much. It's important that you research your doctor. It's important that you like your doctor. I think if you meet somebody and you don't like them, there's lots of doctors out there. Don't let them sit and type on their computer and not talk to you. Engage them. We got to take healthcare back from this. How it used to be. I remember listening to my dad and the relationship my dad had with his patients. We got to get that back. You got to talk to your doctor. Hold them accountable, and the doctors need to hold their patients accountable. And we need to, half my friends I have are my patients, and I think that's the way it should be. It's not the way that it is now, but I think that's the way it should be. There's so much you can do here in this community, medically, and all the cool things that we're doing surgically and non-surgically, and all the new advances and the work that people like Nan do and that the hospital does. Make sure you take control of your healthcare and go see your doctor. Let's go with more questions now. Well, I know that lady. Absolutely.
Can you repeat the question?
She was asking if I consider the Achilles tendon part of the ankle. Yeah, and absolutely. And my surgical training is anywhere below the knee. So yeah, we fix a lot of Achilles tendons actually.
In the morning it's so tight, I have to stretch before I can even get out of bed.
Yes, and you have a little bit of equinus, and I know that from before. So when you have equinus or tightness in your posterior muscle group, so your gastroc, soleus are the two muscles that make your Achilles tendon complex. That's like the little cute little muscle when you wear your heels is the gastroc, and the soleus is like a piece of fish on the inside. Could be a tilapia, man. That needs to be stretched, and there's a proper way to stretch it. And you may be gastroc tight, which I think you were, or soleal tight, or both. And so there you can contour that stretching, and that's where somebody who does these kind of things can kind of come in. So pop in, I'll show you what I mean. Yes?
Okay.
What else can you do besides the stretching? Can you do a surgery after?
You can do Achilles tendon lengthening. TALs or tendo Achilles lengthenings, percutaneous, are a great procedure. Not usually an isolated procedure, usually with reconstruction. If you can't stretch it yourself, what do I recommend? I recommend you go to a physical therapy department and have them work with you.
Now, have you heard any patient ever talk about, you can feel like a burning in there?
In your Achilles tendon?
In the heel?
Yeah, you're tearing. So you're having tearing or swelling, and the edema is pushing on your nerves. You have all kinds of calcaneal nerves that go through there. Your sural nerve runs through there, which is the sensory nerve, which can give you that burning feeling. So either you're swelling, and that's causing the burning, or you're tearing, which is causing the burning, or you're tearing, which is causing swelling, which is causing the burning, which is probably the case.
Okay.
So a heel lift, acutely, if you came to my office with that problem, I give you a heel lift. You walk around in that for 4 to 6 weeks. You either call me at home or you come back in. We go through, okay, how we doing? Is the pain gone? Then we work on stretching you back out once you're healed. Maybe we get an MRI, maybe we don't. I tend to try to treat you first and get an MRI if I need to. Yes? Yeah.
What treatment do you recommend for metatarsalgia?
Metatarsalgia and capsulitis, exactly. 4 foot. Yeah, you don't have a whole lot of dislocation. Is it just under your second?
Right. Just like,
Put your finger right on
well, just like the ball of the
it. Just underneath this guy.
Yeah. Mhm.
So I always say start simple, get complicated. So we can do a little gel pad. We have these really cute gel pads that they kind of slide over your toe, and they fit into most shoes you could probably be wearing them, even with those. And by just putting some gel there and supporting it, you've just lost some of your fat pad on the bottom of your foot. And what's happening is you're getting some bone on ground contact that you don't like. If we can settle that down just with some gel or with some offloading, sometimes a metatarsal pad that goes just behind where that is, we'll put the weight just behind it. 4 or 6 weeks and everything's better. Once it heals up, you're fine. The problem with your feet is they never get a chance to heal up. You're constantly walking on your feet. Foot surgery is terrible because of that. I mean, it swells. So you'll have swelling for a year after the most simple foot surgery. If it's your hand, you just go like this for 2 weeks and everything's cool, but your foot, you just can't. It's a tough go. And non-surgical problems are the same way. You're constantly irritating it every time you get up.
What are your office hours?
I pretty much live there. Yeah, I tried to take some time off today, but I got a little queasy, so I ran down this afternoon. We're seeing a patient this Sunday. I'll make whatever work for you. You can fill out one of these cards, and Megan or Gina will call you. Yeah, Gina will be the real calm, collected one, and Megan will be the real intense one, like a gopher on crack. And if you don't show up on time, she'll call you, and then she'll come to your house. Jody had to leave. We think Jody left because of Megan. We're not sure. She's wonderful. But leave your number. The girls will call you, and we'll work you in. I'm a huge believer in what I do, and I'll do anything to get you in. I think it's silly to have foot pain when there's somebody who knows how to fix it. Oh, well, thank you. And I am taller than this. I really, truly am.
On moon.
Right.
I think I broke my ankle years ago, and
You
I
probably
have this
did.
big lump right here. Would that mean surgery eventually?
Not necessarily, but that's a dorsal exostosis at your metatarsal cuneiform joint, which is just a bone growth from either arthritis or from a broken bone. And probably what it was an intra-articular fracture that went missed on x-ray, or you didn't go in.
I just didn't go in.
Yeah, which is fine. It's just your foot.
Yeah.
And so what happens is it develops over time to where you have to wear these cute little shoes with a hole in them for that bone.
For that bone.
Yeah, and I like those, but yeah, that does limit your shopping times.
So it's going to be. Do I get a better deal because it's going to be 2 for 1, one bundle and one more?
Right. Yeah, it's amazing. We do a lot of other people's. We do a lot of the other foot. I remember they reviewed me at the hospital. I'm probably not supposed to talk about this. I always say something that upsets Nan, but you can delete things, right? So they reviewed me about a year after I was there because they thought I was doing too much revision surgery. And I had the luxury of going to a meeting and telling the review board, well, I don't think you've ever had anybody who's had the patients do the other foot. So yeah, we had the same patient a year later because so many people, particularly this ankle surgery, it's crazy. People don't realize they don't have to live like that. And it's such an easy fix. So I won't do them both at the same time unless you really blink at me and talk me into it. About once a year, some cute little lady like you will talk me into it. One time, it went well. The 4 other times I can think of it, the recovery time is just as long. You don't have a good foot to walk on. One woman fell down the stairs. It was awful. Yeah, so I'm a little gun shy with two at once. So it's always better
How long
to...
does bunion surgery, how long does it take to recoup from that?
Jen?
I'm a feet all the time,
Yeah.
I'm going on 4 months. I still can't quite get in my summer sandals yet, because it's getting better.
Exactly.
How do you not even say,
It's, you need...
Up until 9 o'clock at night.
You were on your feet, and it's really a tough thing. And so when people come in to see me, a lot of times they've been told by somebody, oh, I just need a bunion surgery. Like, I'm gonna go get a lunch, and then we're gonna do your bunion surgery, and I got a meeting. The first thing I'll say to you is, you're crazy, lady. You gotta commit to this. And it's foot surgery is really hard. It's difficult to do. It's very specialized, and in your bunion, as I look at the rotation of your foot in all 3 planes on your big toe, and the differences between your left and your right, secondary to your fracture, maybe your gait cycle, we got a lot to talk about. And what I say to people is this: you will swell for a year. That you notice, Tori. Yeah. But your shoes will go back on, 4 months out, you're living a pretty normal life. Depending upon what your deformity is and what we have to do, usually for a bunion surgery, you're weight bearing right away afterwards. You're in a flat shoe, a little post-operative shoe. Swelling is your enemy. If you can give me 2 weeks of really taking it easy, you and I will be much better friends at 6 weeks. If you have to get back and get up and get going, then there's a little more delay. A lot of it depends on you, a lot of it depends on what's wrong with you. I always tell people if you have a vacation or something you're really looking forward to, do it after. I always tell people in this part of the world, don't ruin your summer over bunion surgery. You had it for 20 years. I think we can wait until November. Because there is a recovery to it. And anybody who tells you different is lying to you or doesn't know better.
So what you said, years ago I had my bunion looked at, and the gentleman who was a foot person said, when it hurts you, then come and see me.
And I say that a lot to people, but then I also sometimes say to people, this is a progressive disorder, and if I can do a surgery on you that's a head procedure, that's such a cute picture, I'm gonna leave that up. If I can cut at the top of your bone, if I can cut you here and fix you, you can walk right away afterwards. If you get past, and there's literature, and there's all, I'm a numbers guy, I'm an angles guy, we're kind of that way, all of us. We kind of get obsessed with all these things, and there's all this research, and we go to these little nerdy meetings where we all sit in a room like this and we talk about feet. And it's basically known that if you have a higher than a 15-degree IM, you may need a base procedure. I can tell you right now, you do on your left foot. That changes everything. So if we can catch you at a point where, and that's why it's important to get in, see a podiatrist like you did, get the x-rays. Podiatrist will know to get a weight-bearing x-ray, 3 views of your foot, so we can see what's going on, see how you're progressing. The problem is it's a tendon imbalance, okay? And so you might go this much for 10 years, and in a year go, and once that big toe is under that second toe, and that second toe pops up and you end up with metatarsalgia and capsulitis and a torn plantar plate, it's a much bigger, more difficult surgery. So yes and no. I say that to people all the time. I always say it's hard to do something when you don't hurt. When you crawl in here and beg me, we'll do surgery. If you're an 8 out of 10, I love taking you to the OR, because I'm pretty sure I can get you down to a 2 or 3 out of 10. If you're a 1 or 2 out of 10, you terrify me to take you to the OR, because I could make you worse. So it's a fine line, and there's a lot more to it than does it hurt or does it not hurt. It's a progressive disorder, and so the fact that you've had it for years is probably that probably bodes well for you. And if it's not hurting terribly, my advice to you would probably be, yeah, just hang on, but let's get some x-rays and see where we're at. So you know, so you're not guessing.
So orthotics would still be good.
Yes, orthotics are wonderful after surgery to prevent a bunion from recurring, and they're great to keep it from progressing, because it's that biomechanical imbalance. It's your feet pulling, trying to catch themselves, that's causing that deformity, in my opinion. Yes. Oh, I'm sorry.
Sorry.
I'm terrified of Nan.
She's next.
What's the best way to treat a callus on the bottom of your foot?
Well, there's a lot of different things you can do, and the acid's fine. There's probably 25% salicylic acid pads you can buy over the counter you can put on. That's a great way to start. Calluses are formed because, do we have a time limit in, or can I just keep rolling? Okay, so there's a biomechanical problem or a bone sticking through or something going on that's forming your callus. So you want to offload that or change that, or you can just keep trimming it. You got to be careful with those razor blade type deals. A pumice stone is much more safe, and what a lot of times people do is they'll come in, get an x-ray, let's find out what the cause. I don't always need to. Usually I can just look and say, okay, here's what's going on. Trim you down really well, and then stay ahead of it with a pumice stone. I have hundreds of patients in my practice who come in and say, I went to wherever and I didn't do my thing and now my callus is back, so we trim it down, and then they can stay ahead of it if they get something. A mechanical debridement at home is really the best. Be careful with the acid pads. They're a great way to start, but you don't want to make that part of your life, and you got to be careful because you can get down into the dermal epidermal junction and you can do some damage, and then that's hard to fix. Yes?
Are shin splints when you're walking, is that a sign of a foot issue?
Not necessarily. It could be a sign of tightness. It could be a sign of a foot issue because if your foot is imbalanced, or when your foot hits the ground, it's imbalanced, you are holding it up. So anterior shin splints, which I'm assuming you're talking right, boom, right here. It's
Julia's daughter, when I walked with her, but what could, she looks like she has an arthritis to me, but what usually is the cause of it is what?
Well, it certainly is something that, when I see shin splints, I see shin splints in March. People start running again, people go out, start doing things again, they've been kind of off. Anytime where there's a change in shoe gear, it's funny, we see a lot of it in November because people go from their nice, supportive tennis shoes into these clunky boots that we wear all day up here, and then you end up with them that way. Usually it's an activity-induced problem that is treated with rest ice compression, that whole rice thing, and people do fine with it. The cause of it, usually some type of biomechanical abnormality or overuse. In other words, in your gait cycle, you're holding that up possibly too long and putting you at a higher risk for getting shin splints, but a totally normal gait cycle can develop shin splints as well. Hold on. Yes?
If you have foot pain as a result of arthritis, can you do anything for that?
We do all kinds of stuff for arthritis. I just did a Swanson total implant. They give me a hard time because I learned this from an old guy I did residency with. I used to have to drive up and buy him corned beef at Shapiro's Deli in Indianapolis, and then he let me do his cases on Friday. It's a double-stemmed silicone implant that actually replaces your big toe joint. We just did one last week, and they're great. Not a lot of young guys do them anymore. Everybody uses metal now. There's hemming implants. I'm a huge fusion guy. My fusion patients love me. You take a foot that doesn't move real well, it's got arthritis, you fuse it, still doesn't move well, and now it doesn't hurt. Midfoot arthritis, that's a tough sell. I mean, I would start by supporting your medial arch all the time. Midfoot surgery, can I say sucks, Nan? Midfoot surgery is really awful. It's a long recovery, it hurts. We do it all the time. But it's something you really got to think about, and you got to decide, where am I at? Do I want to do this? I mean, you're talking a midfoot arthritis kind of deal?
No, it's my husband, so.
Oh, well, good luck getting him into the doctor. Yeah, but yeah, is it in the middle of his foot or is his big toe?
Probably, he hasn't told me exactly where, he just has.
He just likes to bitch. I do that too. Yeah. I just complain. Carrie doesn't really know. She acts sympathetic. Oh yeah. Yeah, I get that too. But yeah, have them come in and seriously, I love this stuff, and I love if I can. There's so many simple things you can do. I mean, I always think of the guy who worked at the hospital who had ankle pain all these years, and the day that I came, it was my first day, that janitor. And he came up, he was my last patient that day. We had all these patients who came down from Wausau, so we had this busy, crazy day. Oh, that was before Jody. Yeah, Jody my first girl couldn't handle me, so they had to import Jody. And so this guy came in, and we injected his ankle. I mean, I still hunt and fish with this guy. It's been 5 years, and I mean, the guy, he hugged me the first year every time he saw me. There's simple things you can do that it's a shame if your husband doesn't come in and just see. And if it's a terrible thing, I'll say, hey, this is a terrible thing, and we'll talk about it.
Don't tell your wife.
Don't tell your wife. Now, hold on. I'm gonna, one more time, I'm going to stay in order, and then I'll just go random. Yeah.
What are your recommendations for treating plantar fasciitis?
Well, when someone comes in my office with plantar fasciitis, first we got to make sure that we're right. Okay, so plantar fasciitis is so common. It's usually the medial 1/3 of your plantar fascia, and usually it's a collapsing arch kind of thing, is really, really sore to the touch. Now there's all different kinds, and there's Baxter's neuritis, there's calcaneal nerve that gets entrapped, there's all these things, and you may or may not read about those things when you go online. Depends on if you go to Medline or if you go to Google or if you know how in depth they're going to get. I start by saying, is this girl tight? In other words, is your calf muscle tight? It's directly related to your plantar fasciitis. Stretching is incredibly important. Stretching properly, 30 seconds in your gastroc, 30 seconds in your soleus. Jody's sick of hearing me say this. I say it to everybody. It's so important. Icing, anti-inflammatories. There's all kinds of, there's COX-1 inhibitors, COX-2 inhibitors. They work differently in your stomach. They're longer, shorter. There's all kinds of stuff. I like diclofenac, which is an anti-inflammatory that's prescription, but naproxen sodium is what I usually tell people. If you called me on the phone, I would say stretch, ice, anti-inflammatories. So stretch, but you gotta stretch correctly. First you gotta make sure you got plantar fasciitis. Lots of patients who come in, I had a woman with a broken heel. Her family doctor had been treating her for plantar fasciitis for a year, just working on that heel. It's tough. You gotta make sure you're right, and then once you're right, stretch it, ice it. Anti-inflammatories, ice 3 times a day. Something that's I love naproxen because it's once in the morning, once at night. So whether you're a normal person, you take it 7 a.m., 7 p.m., or you're me, and you take it 3 a.m. and 3 p.m., just it's steady in your system then for a month. The pain is the inflammation and the tearing of that ligament. So we're trying to calm it down. Orthotics, supportive shoes. Running shoes always have a good medial arch support. Things like that. What do you wear? Oh, those are cute, yeah. Yeah, so, and you'll find a little bit of heel will probably take some pressure off of you, so you'll gravitate toward that, because that takes pressure off your Achilles tendon. And so you're secondhand treating yourself for your plantar fasciitis by elevating your heel. The problem is you're also creating more equinus, so when your heel does go down, you're even tighter now. So, stretch, ice, anti-inflammatories, get some supportive shoes, some inserts. Over-the-counter stuff is cool, I always say spend between $40 and $65 on your over-the-counter orthotics for plantar fasciitis, then they're the good ones. The foamy ones will just, even in a tiny person like you, they'll just squish. In 2 days, they're no good.
Okay, can you show us some stretches?
You want me to show you some stretches?
Yeah.
Sure.
Is that on the table?
On the table. Man, you took this the wrong way early. There's not even a pole here. I don't think I can. We'll start like this, and I'm gonna do just what I told you. Don't let your doctor do. I'm gonna turn my back to you. Well, I can go sideways. You always want to stretch both legs, okay? Don't do just my right foot hurts, so I'm just gonna stretch my right. Do both. Come to a wall, toes to the wall, lean forward, and then you're gonna feel that stretch up in your gastroc up high with your legs straight. Hold it for 30 seconds, and then bend your knee, keeping your heel on the ground. You'll feel the stretch go lower. Get up, try it if you want, get up. You don't need a wall. So this girl's doing it pretty good. So as you lean forward, you'll feel the stretch here, correct? You want to hold it for 30 seconds because your body will kind of contract against that stretch initially. You want to wait. You'll almost get to where you're so good you can feel it when it goes. If you count to 30, you'll get there. Now bend your knee, keeping your heel on the ground. Do you feel it go lower?
I can't keep my heel on the ground though.
I know it's hard.
That is really hard.
Do you feel it go here?
Yeah.
Yep. So that's the stretch. The gastroc component and the soleal component of your Achilles tendon complex, which is your posterior muscle group. So what are you going to do after you do your left leg?
Do the right.
You're going to do your right leg. You're going to do it 30 seconds up. I always say 30 seconds up, 30 seconds down. Okay? 30 seconds up, 30 seconds down. 10 times a day. Which sounds like a lot, but I'm crazy busy and I do it 10 times a day. Do it when you get up, do it when you get to work, do it. I mean, just make it part of your life.
Well, that helps. Good idea.
Yes, ma'am. Absolutely. I do recommend Easy Spirit shoes. This is what I try to pound through to my patients. I am never going to say to you, hey, buy this. Always. I want you to try the shoe on. I want you to understand your problem. And if you need help understanding it, that's what I'm for. Then I want you to understand the shoe you're buying. And that's what the podorathist is for. Or the person selling you shoes, or the 16-year-old kid who dad made him get a job. And, yeah. So the more you know, the better. And then you're not a certain size, there's not a certain brand. I may look at your foot and say, you have kind of a wide toe box and a narrow heel. I think an Asics shoe would be good for you because Asics tends to run that way. Nike has a tendency to do this. Nike changed their shoe about 5 years ago. I have patients tell me all the time, and it's so true. Nike changed their shoe. I mean, they just changed them. So everybody who was wearing Nikes for 20 years, now Nikes don't fit them right. And so I can look at your foot and tell you what's good. Easy Spirit's a great brand. Skechers have really changed the game. Skechers came out with that memory foam, and Skechers had the butt lifter thing,
Yeah.
So that's what kind of put them on the map. My best man at my wedding was their model for years. That was his butt. Yeah. So, yeah, Jason Gerhardt. You can look him up. Good guy. Carrie loves when he comes to visit. He was on Days of Our Lives. Yeah, he's a lot of fun. But Skechers took it to the next level and have really done well with like their memory foam shoes, which can be a blessing or a curse depending upon what's wrong with your feet. I'm not trying to just peddle myself, but I am saying I see people over and over and over again who've been doing damage to themselves for years. Wearing the wrong kind of shoe, doing the wrong kind of thing. Yes, ma'am. Yes? I will always work you in. So, I really am almost kind of sick about work. I'll stay there all night. I'm cool with that. They have a deal worked out with me where I just walk people out. I lock the door when I leave. I work on the weekends. It's a tribute to Jody, who worked with me for years and put up with that crap. And now they've replaced Jody with 2 girls, which they needed to do. And so between the 2 of them, one of them will be there, and we'll get you in. I mean, if you want to get in, plus I think you know someone who could get you in. Yeah. So yeah, we'll get you in whenever it works. I've got the woman I'm seeing Sunday runs a daycare, and she can't get away. She can't get there during the day, so we're going to see her on the weekend.
So I mean, like my mom, for instance, somebody her foot has been bothering her. We played paintball a couple weeks ago, and she kicked the ball without any shoes on. So like something.
Did it turn black and blue?
I don't know what it is. Just keeping bothering her, but like something like that.
Did you count them? Are there still 10 there?
They're all one looks kind of.
One was funny.
But something like that, you would make the appointment with you for.
I would. Yeah, we got great family practice doctors at Riverview. I'm really impressed with them. They spent years without a podiatrist, so they've kind of learned how to do their own thing. I'm a huge, I hate where medicine went, that the interpersonal relationship between doctor and patient has kind of fallen off. I think some of that came with specialization. However, there's a huge benefit for specialization. I mean, you're sitting in a room with a guy who's done 5,000 foot surgeries, and I've seen every crazy thing you can see. And you know, so if you, I recommend coming to see a foot person, and there's good foot people here in town. That, you know, foot people are foot people. We're all a little weird, but we know feet. And you know, if you're going to have surgery, I think you got to do your homework on somebody. I mean, I'll leave you with that. But I do think going and seeing a foot specialist is a great idea. Absolutely. Yes.
Advice for running with bunions?
Running with bunions.
Before or after?
Yeah. Do you have orthotics? What do you wear for shoes when you run?
Right now, I'm New Balance Minimus, but I've tried Brooks.
You did the Minimus and you tried the Brooks? Does your foot squish down when you step up? Yeah. Yeah, and your bunion is very mild. And so one thing that people will do is they'll get a bunion splint. We give them to people in the office all the time. You can kind of hold that toe over. Because what the bunion will do is it deviates your joint, and so then the running, or the repetitive things like running, will actually damage the articular surface, and that's what you want to avoid. So if you can get a spacer to put between your toes, or a bunion splint, when you run, I recommend that to all my bunion runners. I would start like that. And then orthotics are a wonderful thing. I mean, they'll really help control your biomechanics while you run. Because you can exacerbate your bunion by running. Exactly, right? I mean, you know, yeah. So it's pretty easy to do. You're taking a whole day and shoving it into a half hour. How are we doing? Everybody's cool? Oh, we got one finger. What's up?
Is there any merit to the, like the KT tape?
You know, yeah, there's been a lot. That's been kind of a new thing coming up, the physio tape and all these other different things. I don't use it in my office, but I do recommend it, and I do tell people to try it before they come in and see me sometimes. I mean, I'm a huge believer in trying everything and in educating yourself and using the internet and talking to people. And I don't have any positives or negatives for it. What's your particular problem? Yeah, and so, you know, we do strappings in the office where we kind of use tape to kind of hold that arch up. We're doing that to see if orthotics would be helpful to you. Sometimes we cheat and do that for people whose, you know, insurance company doesn't cover their orthotics, so we try this and say, okay, maybe you should really consider. Until your foot pain goes away, you can't believe how nice it is not to have it. And so if we can make it go away for a week, people then are more apt to say, you know what, I'll pay the $488 for my orthotics.
So I was told the only way that insurance company covers you is if you're diabetic.
No, well, yeah, thank you, Jody. I always just kind of cower and then I turn people over to Jody. But yeah, that's not true. There are certain things that may be covered. Toenail debridement, if you're diabetic, with Q9 modifiers, that include 3 out of the 5 in the first category, 2 out of 5 in the second category. I mean, it is so daunting, and if I explained it to you by the time I was done, it'd be different tomorrow. You need to call your insurance company. Exactly, that's a good way to put it too. So yeah, it's tough. Insurance companies are very, very. There's been a lot of changes lately. I can't keep up with it. When we first started, Jody and I used to try calling for people, and we finally said, you know what, you need to call, because by the time we would call, it would change, and then they'd say we can't talk to her, we got to talk to him, and can't talk to him, we got to talk to her, and what does the patient say? And so I always have my patients call their insurance company, pack a lunch because you'll be on the phone for a while. What's that? We do treat neuropathy, and I've recently given the injections a couple different times. Just local anesthetic, you do Marcaine, 0.5% Marcaine. It's really, really, we did 3, 2 of them did really, really well. One guy didn't have any results at all. That's an unproven thing that Medicare won't pay for, but Security Health Plan will. So it's crazy, everything's different. There's a guy named Justin Scher up in Wausau. You'll hear Justin's commercials on TV. He's treating neuropathy now with some laser treatments. That's kind of cutting edge. Neuropathy's a booger. It really is. It's because of sensation loss? Okay. Yeah, and then that's a rational fear if you're starting to lose muscle function. Yeah, absolutely. Yes, ma'am. With what?
It was 15 years ago, I'm not sure, but I'm sure it's not easy to do what you're talking about.
But it might be. I mean, the older it was, the more likely it was silicone. I mean, this was like 40 years ago these guys developed this, yeah. They don't always bend. Don't beat yourself over that. That's not your fault. I mean, sometimes they don't bend. Are they hurting? You know, is it a hemi implant? Do you remember? Was it on one side? Okay.
Ding, 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 ding.
Right. Yeah, exactly. So it's a hemi implant. You had to hear Steve's point? Yeah, I probably know who did that, and I know exactly what he uses, and he's a good surgeon, and you did a good thing. That he's a good guy. If you're having pain, I always say, come on in. There's a million things we can do. We can replace it with a total implant. We can fuse it. There's a million things you can do. If you're having pain in your first metatarsal flange or your big toe joint, that's a total go to a podiatrist, because there's a million things we can do, and most people are really happy when they get that taken care of. That arthritis is terrible. It really can be terrible. Am I done?
Never. So, because it is 7 o'clock, here's what I want you to know. Number one, Dr. Torhorst always sticks around and will talk to you about your personal foot issues, or whether your shoes are cute, because his are. Number two, we have little cards out on the front table as you leave and you get your gift, where you can put your name and your phone number, and it won't be Jody who will call you, but it'll be Megan, the really, or what's Gina, who's more. One of them will call you and get you in right away, because that's what Dr. Torhorst does. I happen to have a friend here, there she is, and she actually brought her son over to Dr. Torhorst's house one evening when he was having toenail fungus.
The kid won the state tournament in basketball like 4 years in a row. It was an emergency.
It was an emergency. We had to get him.
It was a toe emergency.
We had to get him back out on that court.
That's right.
Yes.
Saving lives one toe at a time. That's what.
Do you bring fresh frozen ones up from Florida?
This is pretty fun. We're gonna do that Friday. We'll see how it goes.
Ooh.
Yeah.
Okay.
I haven't done that since residency, so, but it is really cool. That's one of the fun things about having Aspirus get involved with us at Riverview, is the sky's the limit, and we're doing all kinds of cool stuff. It is really neat.
So those are your two things. You can talk to him. He is always welcome to hearing what your concerns are, and you can fill out a card, and we will give you a call. Well, I personally won't, but I could. Someone will call you and get you in on a priority appointment. And he is like that. Dr. Torhorst will he'll fit everybody in during the day. I guarantee that. In fact, if we call and say, I tried to make an appointment, he'll say, what? What?
Yeah,
come into my office now.
So how long are the appointments? I mean, how long is the...
They're as long as they need to be. And so I do, again, Megan will yell at you, I will explain it to you, Gina will just kind of let you think what you want. Sometimes, what I say to people is, when I have a new patient, we try to see you on time. But once you've seen me, you'll understand that I'll give you whatever time you need. So I always say to my other patients, hey, you know what? If you have to wait 15, 20 minutes, I'm sorry, but somebody needed to see me. If we got to run to the ER, we got to do this, we got to do that, or we got somebody who had to be worked in, sometimes you may have to wait. I try not to make it real long. We do really well. The girls work like dogs. They're incredible. They really keep up with me, and they do a lot of things. But your appointment will be as long as it needs to be. And so your first appointment will involve you and I talking about your options and getting some x-rays, and so that we can look at them and know what we're going to do moving forward.
You don't have to worry about saying, we can't get you in for 3 weeks.
They don't say that.
And if they do, it's getting harder and harder. We're getting busier and busier, and I'm having less and less time. And so what we say to people is, I've opened up Friday afternoons now for a section for just new patients, and so we're trying to do it that way. And what I always say to people, if they tell you that, call my cell or call Megan.
By the way, you have his business card in your folders.
It makes you feel really important while you're there.
Oh.
So you are really important while you're there.
And it gives you all the time you need.
There you go. There's a testimony for you, ladies. So let's give Dr. Torhorst a big hand.
And thank you all for coming.
He is certainly one of my favorite aspiring women presenters, and you can see why. Once again, you have his business card. There are cards out there that you can give a name and phone number, and we will give you a call. He will hang around and look at your shoes and whatever else. No, just your shoes and your feet. I'm sorry, that came out wrong. That came out wrong. Ladies, mind your manners. Okay, so before you leave, we have some door prizes. These actually came from our Medi-Spa at Riverview, and they are, I don't know if you've ever heard of this, but this is called Baby Foot, and this is an exfoliator for your feet. So they are like baby feet. Plus, some pretty toenail polish after you've done that. And let me warn you, when you do it, your feet peel for about 5 days. But they are incredible. Like a snake.
Like a snake, she said, ew. You can't wear sandals.
You can't wear sandals. And my husband said, you're wearing socks to bed, right? So, you know where your numbers are. They're in your folders by your name tag. Everybody ready? She's going to do a random up. 79 is up. Do we have 79?
Look at the numbers on your.
Look at the numbers on your name tag. Anybody have a 79?
Going.
Going.
Gun.
Here we go again. Random numbers, search. 88. There we go. You're welcome. What's our next number? Oh, way down. Number 6. Okay. There you go.
And lastly,
Number 57. Number 57. Number 57. Okay, one more. 26. There we go. And ladies, tonight, when you leave, there are Spirit magazines out there. You're all going to get a gift. Compliments of Aspiring Women. I wanted to show you what it was. It is a little, whoops, I have it upside down, manicure set. So please enjoy.